Just have a question for our moderator here.
Yes.
You don't get to ask all the questions. But you're involved in a study looking at TAF-based regimen in hemodialysis.
Sure.
But instinctually, it doesn't seem right to me to use TAF and M-tricytidine in people on hemodialysis. So what do you think?
Well, I think that you can come up with other alternatives, though. It depends. There are people that have very strong kind of ties to tenofovir. In our clinic, we had people on once weekly tenofovir and TDF. Sorry, and the levels with TAF daily for people on chronic dialysis, and these were all people that were on chronic dialysis. They weren't transplant candidates, so it's kind of a different setting. Yeah. But I think there are other alternatives. I think if you need to use it in that setting, I think
right now I'm struggling with a very difficult case. I can get some consults here of a person. He has chronic hepatitis B, and almost certainly has resistance to lamivudine.
Right.
So
you can test for that.
No, but now he's suppressed because he's on TAF-based regimen, but he's losing his kidney function because of aging and comorbidities, not because of TAF. I don't think there's a ready solution to that one.
No, I think that's right. But in terms of tenofovir exposures, they'll be quite low.
It's good. They're but higher than estimated GFR 15 now.
I think. But again, depending on his resistance profile, I think actually dolutegravir, rilpivirine is.
But Hep B. Except for the Hep B.
Oh yes, Hep B. Right, of course.
Yeah, and entecavir normally would be our backup, but with lamivudine resistance.
It's this is someone who's been infected since the early 90s.
I would use TAF.
That's what I'm doing.
I would use TAF. Okay, so let's flip over to maybe anything else to say about switching. This is one of our topics.
I think this is, if you ever want to have a setting where you want to get the HIV experts involved, it's really before switching ART. I think a lot of our patients are so stable now that they can be managed by primary care, general internists, family practitioners, people who are not HIV specialists. But if you're switching a regimen, get some input from somebody.
I think that's the really important caveat about that is that we get opportunities to switch because new drugs keep coming out. And oftentimes I think there is some pressure on treating physicians to do something new and different instead of the same old thing that has always happened. There has to be a good reason to switch. There has to be a good reason to switch, not just because the fact that this person told you that there's a brand new drug out there. So I think that's really the important thing. And when you do make that decision and you have questions, particularly about previous treatment history, you really need to get help with that because you can make bad decisions and actually cause harm by switching in not an appropriate way.
Although I would just say that there are studies that show people who are on a efavirenz-based regimen who don't report any symptoms associated with efavirenz feel better after a switch to a non-efavirenz regimen. So I think it's always worth talking to a patient who's on an older combination to carefully discuss the presence of maybe some subtle symptoms that may be associated with that combination.
Yeah, I think
and careful attention to lipid levels and and risk for particularly on an efavirenz inclusive fixed dose combination. They're on an older formulation of tenofovir with renal and potentially bone effects. So there are things to pay attention to, and although things aren't broke, it doesn't mean that things aren't slowly deteriorating, and maybe a more modern, less toxic regimen is something to be considered.
I mean, I tell the fellows that patients have the right to be on the simplest, safest therapy possible, and that's kind of our job. And that fits into their life in terms of cost and cost effectiveness for them. Because sometimes people, at least in North Carolina, sometimes the simplest regimen is sometimes not the affordable regimen. But in general, but I completely agree with Paul. The problems that I've seen are people who get switched when there aren't quite enough data or someone
hasn't taken the
really thought,
time
right.
to really. I mean, this is why ID doctors are paid so well. Because everyone laughed immediately. This is because
I'm not laughing, I'm writing that down.
because we take the time and energy to go through all of those historical resistance tests that go back now to the late 90s, and and really scrutinize them before making these changes, because the stakes are very high.
Right.
The last thing we want to do is switch somebody and have them get resistance to a new drug class, especially integrase class. So
Yeah, I agree.